Hello everyone. Today we'll be discussing about ptosis. Ptosis is a off-dial concept, but it is also important in general medicine. In fact, it comes under third canon of examination. Whilst there are a lot of causes for ptosis when it comes to medicine, but we here we'll be confining our discussion to congenital causes as well as acquired causes, and mainly on the treatment aspect. Because the most common cause of ptosis in ophthalmology setting is aponeurotic ptosis, which is like a senile ptosis, which occurs with age. So let's dive into the concept of ptosis. Let's start with the definition. Its clinical types, etiological types, which is the reason for which ptosis is happening. Let's move on to then a clinical evaluation on how we'll approach ptosis and find out the etiology and then treatment aspect. Okay, let's start the discussion. To define ptosis, most of us would have come across this, from ages from first year to second year subjects. It is the abnormal drooping of upper eyelids. Normally, the upper eyelids cover 2 millimeter of the cornea, and by this here we mean cornea. It's actually cornea and not the eyeball as such. It normally covers 2 millimeter of the cornea up till here. When the eyelids go down beneath 2 millimeter, then it is called ptosis. Okay. Clinical types, uh, it can be congenital ptosis or it can be acquired ptosis. Congenital means something which is coming by birth and not acquired along the life course. Okay. Congenital ptosis, uh, mainly congenital ptosis occurs because of, say, eyelid contraction causes maintenance of the lid posture. When there is a defect in the muscles that maintain the eyelid posture, it results in ptosis. When the defect is maldevelopment of the muscle holding the eyelids, then it is congenital ptosis. There is maldevelopment of certain muscles. Most commonly, it is levator palpebrae superioris muscle, LPS. Okay. Um, or we can also call this as congenital weakness of levator palpebrae superioris. Levator palpebrae superioris weakness is the prime cause of congenital ptosis. What are the features? Congenital ptosis, as the name suggests, is occurring from birth. So the onset will be from birth, but the child can present the presentation of the child, the age of presentation may vary. Although it occurs right from the birth, onset is from the birth. Lid crease. See, while acquired ptosis is due to other reasons like neurological, myogenic, etc., congenital ptosis is due since it is due to maldevelopment. It also leads to certain other features in the eye. The lid crease, which is usually present around here, it's a line due to skin fold, is absent. Is usually absent in congenital ptosis. The maldevelopment also causes lid crease absence or diminish. Okay. Lid lag. Now, uh, while all the positions, when we examine the congenital ptosis case, we find that if we ask the patient to look all the direction, make the patient go in all the gazes, then we find that on down gaze, the ptotic lid, the where the side of the lesion is there, that is actually higher than the normal lid in only in down gaze. Okay. Uh, this is due to tethering effect of the abnormal LPS muscle. It holds down the lid while the other eye, the lid goes down in the down gaze. So always remember, lid lag is absent in case of congenital ptosis, whereas in acquired ptosis, there is the ptotic eye will be lower than the normal eye. Important differentiating point when it comes to approach to a patient. Next, LPS function. Again, LPS function will be deranged in congenital ptosis because, as we already discussed, this is due to the maldevelopment of LPS muscle. See, forms, it's not forms as such, it is the etiology of congenital ptosis. We all know the maldevelopment of LPS is the reason, but what is the cause prior to the maldevelopment or types of maldevelopment? We can say is there are four types basically. One is simple congenital ptosis where there is no associated, no other features, no other additional features. We can say uh, blepharophimosis syndrome. Blepharophimosis syndrome. See, phimosis means unable to retract something. Phimosis will also come in penis, will come across in penis, where circumcision might be required. Similarly, blepharophimosis means when the patient tries to open the eyes, the lid cannot go back into normal position. It holds down there, causing the ptosis. This is called phimosis, blepharophimosis. Unable to retract the eyelid. In blepharophimosis syndrome, there is congenital ptosis. The components of blepharophimosis syndrome, congenital ptosis. There are other features. Blepharophimosis itself will be one feature. Telecanthus and epicanthus inversion. Okay, it's a syndromic disease. So, along with congenital ptosis, you can observe other features. Congenital synkinetic ptosis. Well, to explain, it is also called Marcus Gunn jaw winking ptosis. See here, uh, the eyelid gets retracted, means it goes back to normal on movement of the jaw. When the patient does jaw movements, there is contraction or stimulation of pterygoid muscle, all other muscles of mastication, along with pterygoid muscle. One side, when one side pterygoid muscle contracts, the levator palpebrae is also stimulated, which causes retraction back of the eyelids. Means the ptosis is absent at that time. This is a complex phenomena where it's also called trigemino-oculomotor synkinesis. See, synkinesis. Together, when the two muscles, the trigeminal pterygoid muscle is supplied by the fifth nerve, whereas LPS is supplied by the third nerve. These two muscles supplied by two different nerves independently. See, the jaw movement need not stimulate the third nerve. But here, due to trigemino-oculomotor synkinesis, normally in normal people, third nerve and the fifth nerve are stimulated independently. One stimulation doesn't need not cause stimulation of the other nerve, but here there is synkinesis. Stimulation of pterygoid muscle by the fifth nerve automatically causes stimulation of third nerve, which causes LPS contraction, which causes retraction of the eyelid. Okay, it can be said that these two cranial nerves have simultaneous a coordinated movement. See, you can see here. Normally, I mean, in simple condition, there is ptosis of one side under movement or jaw retraction, pterygoid muscle contraction. The third nerve also gets stimulated, which causes retraction back of eyelid. This is also called congenital synkinetic. This is also called Marcus Gunn jaw winking ptosis. Okay. Now, these are some photographs of congenital ptosis. Obviously, when a child comes to the ophthalmic clinic with this presentation, we have to think about congenital ptosis. Whilst there are other differentials for acquired ptosis in a child, we'll come to that point. Okay. Now, let's move on to acquired ptosis. Acquired ptosis means drooping down of eyelids in due course of life due to acquired reasons and not present since birth. There are different types: uh, neurogenic, myogenic, aponeurotic, and mechanical. Neurogenic ptosis, they often present to the medicine OPD. Um, Various reasons for neurogenic OPD basic meaning is there is some palsy or abnormal nerve, the problem in nerve stimulation, third nerve stimulation, which causes relaxation of LPS muscle, which causes ptosis. Various reasons are third nerve palsy. Third nerve palsy as a part of any midbrain syndrome or stroke, lower motor neuron palsy, cranial nerve palsy also occur in diabetes mellitus. Various reasons might be there for third nerve palsy, but third nerve palsy is the prime reason for neurogenic ptosis. Horner syndrome, which is nothing but sympathetic palsy, oculosympathetic palsy. There is meiosis and hydrosis. Meiosis is contraction of, pupillary contraction. It's actually due to paralysis of dilator pupillae. Dilator pupillae muscle is not working, and that's why dilation is not possible. So the pupil remains in a contracted state. Ptosis here occurs due to paralysis of Muller's muscle, which is superior tarsal muscle. Reduced swelling, which is called anhidrosis. Other features include enophthalmos and enophthalmos, loss of ciliary reflex. What is that? Ciliospinal reflex, right? Ciliospinal reflex, etc. Other cause is multiple sclerosis. Now remember, multiple sclerosis in children, it can occur in children, it can occur in adults. Multiple sclerosis, often there is ascending paralysis. There is optic neuritis. Optic neuritis is often the first presentation of multiple sclerosis. So you have to correlate with all those things if you have to come to a diagnosis of multiple sclerosis. Ophthalmoplegic migraine. This is type of migraine where there is aura. Migraine without aura is classic aura. Migraine with aura is non-classic aura. Here there is paralysis of extraocular muscles due to the migraine in itself. This is one more cause of neurogenic ptosis. Next, myogenic ptosis. Myogenic ptosis again, it can occur as a part of pathology in the muscle or pathology in the neuromuscular junction. Muscle involvement is usually it's a genetic disease, ocular myopathy or dystrophia myotonica or muscular dystrophy involving the LPS muscle. Those things, it's actually a gene-related disease which gets expressed later in the life. That also comes under acquired ptosis, even though it's a genetic disease. Genetic disease are myotonic dystrophia myotonica. Um, Ocular myopathy. Again, not all diseases are genetic. Muscular dystrophy, etc. Neuromuscular junction involvement include classical disease, which is myasthenia gravis. A lot of times, myasthenia gravis presents with other muscle involvement, proximal muscle involvement as well. But many times, ptosis can be the only symptom. Uh, Thyrotoxicosis and Lambert-Eaton syndrome can be other differentials for this. Lambert-Eaton syndrome is due to production of antibodies against calcium channels. Well, Lambert-Eaton syndrome happens to be a paraneoplastic syndrome of lung cancer. So it can be a paraneoplastic of many diseases. That should be kept in mind. Thyrotoxicosis often causes exophthalmos, that is only in Graves' disease, which is a form of which causes thyrotoxicosis. And only in Graves' disease there is true ophthalmopathy, where there is accumulation of connective tissue and edema behind the eyes, which causes protrusion of eyeball. But here there is, along with there is deposition of connective tissue and infiltration of leukocytes, which causes abnormalities of muscle. There is leukocyte infiltration and fatty changes in the muscle. If it happens in the extraocular muscle, there occurs ptosis. Features of thyrotoxicosis, systemic features should be correlated if we want to come to the diagnosis of thyrotoxicosis. Continuing the session. The third clinical type is aponeurotic ptosis. You see, levator palpebrae superiorus, the LPS, has got has happened to have a aponeurosis. Aponeurosis tendon means the one which flattens at the end of its insertion. It's a flat tendon. So it happens that during continuous contraction relaxation and with age, it gets stretched and it gets weakened up, and there is somehow there is dehiscence. So as a chance factor, there is dehiscence or sometimes disinsertion of levator aponeurosis. Okay, this is the pathophysiology of aponeurotic ptosis. It's a pathology in the tendon which undergoes weakness continuously with age. The muscle function as such, normal LPS function is present. That means you don't have any Burke's test will will not reveal any disjunction. Okay. Um, the reasons of aponeurotic ptosis is most common. This is the most common type of ptosis in an off-style OPD. If you sit down, most common type is aponeurotic ptosis, the one which occurs with age, involutional ptosis. This can occur sometime as a part of post-operative complication in certain vitrectomy, even in cataract surgeries. It can occur. Uh, Another reason is blepharochalasis. This is due to continuous inflammation of the leg. The tendon also gets damaged. Infective foci should be present as a part of blepharochalasis. Aponeurotic ptosis can also happen as a part of traumatic dehiscence. Okay, so blepharochalasis, traumatic dehiscence, postoperative complication, involutional sclerosis, age-related. Age-related is the most common because in elderly people. Clinical features of this aponeurotic ptosis, we have to compare this aponeurotic ptosis clinical feature with congenital ptosis. The lid crease is actually high arc. High arc lid crease will be present. Uh, in compared to congenital ptosis, which has got an absent lid crease. It may be absent or diminished. The ptosis is mild to moderate. We'll study how to grade the ptosis. Lid lag. One thing we should talk about again. Compare with congenital ptosis, where the LPS of the ptosis in the ptotic eye, the lid is higher than the normal compared to the normal eyelid. In acquired in aponeurotic ptosis, compared with the normal eye, it will be actually more lower. It appears to have more ptosis when there is down gaze. Okay? In checked in down gaze, always checked in down gaze. LPS function is normal, we know it. Whereas in congenital ptosis, it is due to maldevelopment of muscles and areas surrounding it. So, LPS function will somewhere between mild and severe, poor LPS function. Okay, the ptosis will be mild to moderate. In congenital ptosis, the ptosis can be very severe. The crease will be higher, whereas in congenital ptosis, it is absent or diminished. Next, mechanical ptosis occurs as a part of see, the lid can have heavy weights due to edema, due to continuous fibrosis, mainly due to tumors, eyelid tumors. It also commonly occurs as a part of chalazion. We know multiple chalasia can cause heavy weight on the eyelid, which can droop down. So these are the reasons for mechanical ptosis. It's nothing but gravitational pressure occurring on the lid, which causes it to droop down. Tumors again cause weight on the on the eyelid. Benign tumors like papillomas, certain keratosis, xeroderma pigmentosis can be observed in eyelid. Basal cell carcinoma and malignant melanoma can also occur. Even sebaceous gland carcinoma can also occur in eyelid. That can cause heavy weight, excessive weight, and thus ptosis. Ocular pemphigoid is a part of inflammation. The reason for ptosis in ocular pemphigoid is inflammation, which causes edema and then ptosis. This condition will be obviously associated with other clinical features which we have differentiated from. Okay. Now, approach when ptosis case. Um, First, history. We'll start how do we examine, how do we clinical evaluation of an ptosis case. Uh, First, history. Onset has to be asked. Obviously, child coming with ptosis, infant coming with ptosis, which the parent have somehow observed, is due to congenital reason, and all the congenital reasons have to be ticked off or ruled out. Family history again important for congenital ptosis. Any history of trauma will tell us aponeurotic ptosis. Again, there is problem with the dehiscence post trauma, thus causing aponeurotic ptosis. Any operation or surgery, previous surgery, any surgery might have caused LPS rupture or a dehiscence. As all surgeries are an insult to the body. Commonly, retinal detachment surgeries, vitrectomies, cataract surgeries would cause a postoperative complication of ptosis. Examination. First thing to rule out is, yeah, we will have to examine whether it is unilateral, bilateral, all the MRDs. We have to measure the ptosis distance, the amount of ptosis. But first, we have to rule out pseudotosis. Pseudotosis means there is no actual lid pathology in it. But for example, let's take an example and talk. Things like microphthalmia, thesis bulbi, microphthalmia, hypertropia, dermatochalasis would cause there would be no pressure from the eyeball, from the globe in microphthalmia to push out the eyelid. Since there is no pressure, if this is the eyelid and this is the globe, since the globe is too small, there is no pressure on the eyelid to move the eyelid out. So there will be obviously the eyelid appears to be drooled out, drooled downwards, and the cornea will not be visible completely. More than 2 millimeter appear to have been covered. This is not actual ptosis, and there is no LPS pathology or tendon problem. There is no aponeurotic ptosis, or there is no neurologic causes here. It's just that the other parts of the eye which are abnormal are causing problem and appear to have ptosis. This is called pseudotosis. Microphthalmos is one cause. Apart from that, thesis bulbi, hydrophobia, dermatochalasis, sorry, etc. Now, coming to the actual ptosis examination, first check whether it is unilateral or bilateral. In traumatic or surgical post-op complication cases, it will be unilateral. Otherwise, most of the things will be bilateral. Myasthenia gravis, Lambert-Eaton syndrome, Turner palsy, Horner syndrome, most of them will be bilateral. Okay. Uh, all the myopathies, dystrophies will be bilateral. Lid crease, lid crease have to be properly examined for, because we know the comparison between congenital and acquired. Lid crease will be absent in congenital causes due to maldevelopment of skin fold there. Lid crease is a very important part of the examination. Apart from that, Bell's phenomena, whether there or not. Look, Bell's phenomena, it so happens that Bell's phenomena is normal. When we forcefully close our eyes, there is upward and outward rolling of eyeball. It is said to be a protective reflex. This is normal case and it is not observed in all cases. But in case of orbicularis oculi weakness or any other extraocular muscle weakness, this is seen, properly seen. And if it is absent also, it is pathological and tells there is extraocular muscle involvement and there is certain definitive neurological phenomena. Bell's phenomena has to be examined whether there or not. Jaw winking phenomena, where the opening of jaw will correct the ptosis. Again, congenital synkinesis ptosis we have read. Any other weakness of extraocular muscle, if present, would tell us that uh, this is an example of all the muscles are involved, so it may be a dystrophy or a dystrophia myotonica or ocular dystrophies. Okay, so all the etiologies behind this should be ruled out. Next, after examination among the part of it, one part is done. Other parts are the amount of doses should be evaluated. Amount of doses, um, it is measured by using scale. The uh, part of cornea covered by the eyelid. The total part of cornea covered by the eyelid, if the eyelid is here, the total part of the cornea covered by eyelid is to be examined. If it is 4 millimeter, finally some amount will get. We have to minus 2 millimeter from it because 2 millimeter is the normally covered corneal part by the eyelid. Apart from that, how much more it is covered, that much is the amount of doses. We have to grade it. Mild is 2 millimeter, moderate, moderate is 3 millimeter. It's consecutive numbers. Severe is 4 millimeter. Okay, that's a simple test using scale. Uh, Now, MRD. What is MRD? Margin reflex distance. It's very simple. The If this is the eyelid margin, the distance from if this is the pupil. When in this test, the examiner has to hold a torchlight in front of the eye, and the corneal light reflex. This is the light reflex that will be shown on the pupil. That will be we'll see on the pupil. The distance from upper eyelid margin to this corneal light reflex is called MRD, margin reflex distance. It's called MRD1. In cases of ptosis, obviously the upper lid margin would have come down. Then the MRD will go on decreasing. Normally it is 4 millimeter, and as ptosis progresses, the distance goes on decreasingly. The MRD goes on decreases. 2 millimeter for moderate, 1 millimeter for 2 millimeter for mild. Moderate is 1 millimeter. Complete zero is 0 millimeter. Complete zero will be severe. MRD2 is not of much significance for us. It is the distance from corneal light reflex to the center of lower lid margin. MRD1 plus MRD2 is the palpebral fissure height, PFH. That makes complete sense. As total, the MRD1 and MRD2 is palpebral fissure height, obviously. Okay. Next is assessment of LPS function. Levator palpebral superior's function is assessed by something called Berg's test. Wait, hang on. See, this is called Berg's test. Um, Here, um, first, the examiner has to apply hold his thumb on the against the brow, because frontalis muscle action should be stopped. Only LPS function we are assessing here. So hold the thumb against the brow and inhibit frontalis muscle. Ask the patient to look down and hold the scale tip to the eyelid margin. Now ask the patient to look up. Measure the distance from the eyelid margin in the second position from the tip of the scale. That distance should be taken out. Um, this is called excursion. Okay. Excursion means moving away. We are checking the power of the LPS muscle. How well can it contract, or how well it contracts. If it contracts nicely and is normal, this distance would be around 15 millimeter. Okay, amount of excursion. If in ptosis, since the LPS is dysfunctional and cannot contract properly, the eyelids would come down and the total distance would reduce. If it in ptosis, it may only be this much. Okay, so the eyelid margin to the tip of the scale after holding thumb against the frontalis muscle against the brow, inhibiting the frontalis muscle. This is the LPS function. Uh, in ptosis, the excursion distance goes on decreases around 8 millimeter for severe ptosis will be there. Okay, these are the examination. In certain cases, if you are suspecting myasthenia, you can do a special investigation might be required. If you are suspecting some neurological causes, in cases of MS with other features involved, you can send for an MRI. So investigations will vary depending upon the what we get in the examination and history. In cases of if myasthenia is suspected, hydrophonium test is given. A fancy name is given, which is called tensilon test. It is nothing but hydrophonium test, which you have learned in pharma. It is also used to differentiate between myasthenic crisis and cholinergic crisis. We can also use some neurological MRIs and CTs to rule out nerve pathologies. Other clinical examinations will be carried out accordingly, depending upon the history and examination here. Uh, Coming to the treatment part, look, it's always surgical, almost always surgical, except one cause, which is myasthenia gravis, in which again cholinergic drugs would help. Again, it is chronic disease and even azathioprine, thymectomy, plasmapheresis, many things are done which will cure the symptoms all over the body due to myasthenia. So eventually it will cure even the ptosis. So apart from that, always it's surgical. Remember, in severe cases, as we graded mild, moderate, and severe, which is 4 millimeter of 4 millimeter ptosis. The total cornea getting covered is 4 millimeter. The action should be taken immediately as complete light deprivation occurs in severe ptosis, and it may lead to amblyopias. I mean, the stimulus deprivation amblyopia, where the nerve function, optic nerve function deteriorates without light. That needs early intervention. For most of the things is surgical. Let's go like for congenital ptosis and for acquired ptosis, little difference is there in treatment part. Ultimately, surgery is the only option, and surgical methods are same for both congenital as well as acquired ptosis. For congenital ptosis, first for mild and moderate ptosis with good LPS function, the mild and moderate we say is based upon the degree of ptosis, which is 2 millimeter and 3 millimeter respectively. For mild and moderate ptosis, we go for uh, tarsoconjunctivo it's operation where the incision is given first the eyelid is averted and incision is given on the palpebral conjunctiva. After that, skin, uh, part of superior tarsal border and Muller's muscle is resected out, and the resected edge is sutured back again. The incised edges are sutured back again. You can see in this figure. This is the averted lid. The palpebral conjunctiva and incision is given. Incision is given and muscle and superior tarsal border, part of superior tarsal border is taken up, and the resected edges are sutured back. Okay. This is called Fasanella servate operation. Fasanella servate operation, also called tarsoconjunctivomolectomy. The procedure's name, also called as Fasanella servate operation. Second operation, which is more common, is for moderate and this is done for mild ptosis only. I'm sorry, only for mild ptosis, and this is for moderate and severe ptosis. Severe ptosis. Then liver resection, LPS, a part of LPS muscle is taken out. Um, this needs some explanation actually. See, again, two approaches are there. One is directly on the skin, giving incision on the skin and taking out taking out the LPS muscle, which is called Everbush operation. Everbush approach, sorry. Particularly useful for big muscle resection when large amounts of muscle has to be removed out in severe ptosis or poor function LPS. Another one is Blakowski's operation. Blakowski's approach in which the incision is given on the palpebral conjunctiva, and here you cannot remove large muscles, but is more commonly done. Um, the amount of elevator palpebral muscle removing is actually index of the eye surgeon itself. It's actually index of ophthalmologist. Means he will assess how much muscle has to be removed once he gives an incision. Upon opening the field itself, we can find out how much muscle has to be resected out. But however, on paper, theoretically, it is possible to tell in case of mild to moderate doses with good LPS function, around 16 has to be resected out. With moderate LPS function, 18 to 20 With poor LPS function, 23 to up to 23 LPS can be resected out. In severe doses, with in severe doses with poor function around 24 that is maximum LPS resection can be done. But in severe doses with poor LPS function, levator resection is contraindicated, so it cannot be done with severe doses with poor LPS function. Other one operation which can be used even all this is contraindicated or we can't do properly, like the big muscle has to be resected. Then frontalis sling operation is done, which is also called bro suspension. Which is also called bro suspension. It's a simple surgery where the LPS muscle is not resected out, but it is connected to the frontalis muscle using some material. It can be prosthetic materials like silica, but most commonly fascial lata of thigh. Yeah, the fascial lata present in the thigh is taken out and used as a sling. Is connected from the LPS to the frontalis muscle. Um, this operation is preferred when there is poor function of LPS. Poor function of LPS. Now, in certain cases like jaw linking phenomena, LPS resection is combined with frontalis sling operation. Okay, this is an extra point where it can be written in paper. Now, one more thing to be added here: treatment for acquired ptosis. It's just congenital ptosis. For acquired ptosis, treat the cause first, and the ptosis might resolve. As such, in myasthenia gravis, treat the cause, like if there is a stroke, and then we have to treat the stroke. We can treat the ptosis. So actual etiology or actual pathology we have to treat. In congenital ptosis, actual pathology is maldevelopment. So we are dissecting the muscle. That is the solution. We are right on logic. But whereas in acquired ptosis, apart from that aponeurotic ptosis, which is actually the most common type, for other reasons for acquired ptosis, we have to treat the cause. Automatically, the ptosis might resolve. Apart from that, finally, if cause is not treatable, we can do surgery to treat the ptosis. It should be delayed for 6 months. It should be delayed for 6 months. After that, only the surgery should be done. Again, the surgical approaches and the surgeries are all the same thing. Specifically, for third nerve palsy, frontalis sling operation should be preferred. The bro suspension, and for Horner syndrome, you specifically want to do Fasanella operation, Fasanella servata operation. Okay.